Hey everyone, and welcome. Today, we're doing a really practical run through on a topic that, let's be honest, comes up constantly at the pharmacy: traveler's diarrhea. We're going to break down exactly how to give clear, effective counseling so you can prepare your patients for the worst and they can actually enjoy their trip.
Okay, so let's just picture this, because we've all been there. A patient comes up to your counter, totally thrilled about their trip to somewhere amazing, but you can see that little bit of worry in their eyes. They're worried about getting sick. What you say in these next few minutes is absolutely crucial. So we're going to build a really clear, evidence-based framework for that exact conversation.
All right, here's our game plan. We'll walk through this in 5 steps. First, just setting up the consultation and defining the problem. Second, the absolute must-knows for prevention. Third, the self-treatment algorithm, what to do when things go wrong. Fourth, the super important advice on standby antibiotics. And finally, we'll touch on special populations who need that extra bit of care.
Let's start right at the beginning. Before we can even give advice, we have to make sure that we and the patient are speaking the same language. The very first step is defining what we actually mean by traveler's diarrhea. Now, this is really the key to the whole thing. The way we define TD has totally shifted. We're not counting stools anymore. It's all about functional impact. And this is just a much more practical way for a traveler to figure out what's going on. So mild, it's annoying, but it's tolerable. Moderate, okay, now it's distressing and it's messing with their plans. And severe, they're stuck in the hotel room, completely incapacitated. And of course, dysentery, any sign of blood, that is always considered severe. This simple framework is the foundation for their entire action plan. So once everyone's on the same page about what severe actually feels like, we can move on to probably the most important part of this whole conversation: prevention. Because look, it's always better to prevent TD than to have to treat it. This is where you really empower your patient. And the foundation of all prevention is actually pretty simple stuff. You can break it down into 3 key areas for them. Number 1, water safety. That means boiled, bottled, or properly treated water, and, this is a big one, no ice. Not unless they are 100% sure it's made from safe water. Second, food safety. The old saying is still the best: boil it, cook it, peel it, or forget it. And third, hand hygiene. You can't beat good old soap and water, but an alcohol-based sanitizer is a great backup. So the inevitable question comes up: what about taking something to prevent it? The 2 options are bismuth subsalicylate, BSS, and antibiotics. And here's the key message: routine antibiotic use for prevention is not recommended. It's a big no. The risks, side effects, C. diff, and especially driving antibiotic resistance just far outweigh the benefits for the average person. BSS can be a decent option for short trips, but antibiotics, those should only be for the absolute highest risk people on the most critical trips. So if you and the patient decide BSS is a good idea, there are a few non-negotiable counseling points. You have to warn them about the blackening of the tongue and stools. It's harmless, but it can be really alarming. And more importantly, black stool can be confused with melena, which is digested blood, creating a whole lot of unnecessary panic. And of course, you have to screen for contraindications. So avoid it in anyone on anticoagulants, people with salicylic allergies, young kids, and during pregnancy.
Okay, but we all know that even with the best prevention plan in the world, TD can still happen. So this next part is the patient's in-travel action plan. This is the simple, step-by-step guide you give them for what to do when symptoms show up. And the entire algorithm, the whole thing, it all hinges on one simple question they have to ask themselves. It goes right back to those definitions we talked about. They just need to think, based on how this is affecting me, is this mild or is it moderate to severe? Their answer is going to tell them exactly what to do next. And here is that plan. It's a 2-path system. For mild diarrhea, it's all about supportive care. The absolute cornerstone is oral rehydration therapy. Then for symptoms, they can use loperamide or BSS. No antibiotics needed, period. But if that diarrhea is moderate or severe, if it's ruining their trip, that's when the plan escalates. That's the green light to start their standby antibiotic. They can also add loperamide right along with it to get symptoms under control faster, and of course, they have to keep up with the hydration. I really can't stress this enough. Oral rehydration therapy is the single most important part of treatment. Dehydration is the real enemy here. Tell every single traveler to pack some commercial sachets, but also give them this simple, life-saving emergency recipe just in case. Into 1 liter of safe water, just stir in 6 level teaspoons of sugar and a half teaspoon of salt. That's it. It's simple, but it's incredibly effective.
Loperamide is in pretty much every travel kit, right? So we have to be super clear on how to use it safely. Yeah, it's great for symptom relief in those mild to moderate cases. You'll want to mention the usual side effects like cramping or dizziness. But here's the critical safety point. It's generally not a good idea to use it alone if the person has a high fever or bloody stools, because there's a theoretical risk it could make the infection stick around longer. And, of course, it's a definite no for kids under 2. Okay, now for what is probably the most nuanced part of this whole consultation, the standby antibiotic. This isn't just about picking a drug. This is about teaching responsible use and making sure the patient understands the very real risks. So, here's where your expertise as a pharmacist really shines. The choice of antibiotic is not one size fits all. It completely depends on where they are going. For most of Latin America and Africa, a fluoroquinolone like Cipro is still a good bet. But, and this is a big but, for Southeast Asia, so think Thailand, India, that whole region, there's widespread resistance to fluoroquinolones. So in those places, azithromycin is the clear antibiotic of choice. But before we even think about writing that script, we have to talk about the dark side. A big analysis found that taking any antibiotic while traveling increases your odds of coming home colonized with a multi-drug-resistant organism by almost 2.5 times. And that's why we have to be so careful. That same study showed that fluoroquinolones are the worst offenders by a long shot, increasing the odds of bringing home a superbug by almost 5 times. This isn't just a personal risk to the traveler. They can bring these resistant bacteria home to their family, their community. It's a really powerful point to make when you're talking about antibiotic stewardship. And finally, let's quickly touch on how this all changes for a few special populations. The standard advice needs some careful tweaks for children and for travelers who are pregnant or breastfeeding. This table really sums it up nicely. For all of these groups, oral rehydration therapy is still king. It's the absolute priority. Azithromycin is the antibiotic we reach for because it's considered safe. Loperamide is okay in pregnancy and breastfeeding, and you can use it cautiously in kids over 2. So what's off the table? Bismuth subsalicylate is a no-go for all of them. We're also steering clear of fluoroquinolones. And one little detail, pregnant or breastfeeding travelers should also avoid using iodine to purify water. So, to wrap it all up, let's boil this entire conversation down into 5 key takeaways. 1. Teach patients to judge severity by how it affects their plans, not by numbers. 2. Hammer home that prevention, food, water, hands is everything. 3. For mild TD, it's just supportive care with ORT and something for symptoms. 4. For severe TD, that's when you use a standby antibiotic, but one that's chosen specifically for their destination. And 5. Always talk about the serious risk of antibiotic resistance. And that just leaves us with a final question to take back to your practice. The world of infectious diseases and resistance is always changing. As pharmacists, our role in promoting good antibiotic stewardship has never been more critical. So the question really is, how will your travel advice continue to evolve to meet that challenge? Thanks for tuning in.